That is noon, so I think we should probably jump in. I know folks will probably still be streaming in, but for the sake of time, I know we have a lot to cover, so I'd love to start off the discussion and thank everybody for joining us and taking your lunch hour, your coffee break to talk with some of healthcare's top thought leaders and influencers, really about the changing landscape of the healthcare industry and the importance of infrastructure and some of these policies and regulations during these unprecedented times. My name is Melissa Erickson, and I'm a solutions lead in the Velatura team. And I've been working downstream of these federal interoperability rules for about a year now and working through strategies and ways to best implement this immense rule set really in a challenging time that we're in. Which is why I'm so honored to be able to virtually sit with this diverse group of healthcare leaders to really untangle what feels like an overwhelming sense of changing policies, regulations, and standards in light of this global pandemic that has truly reshaped our lives and our healthcare system. Our goal is to gain insight into how organizations can best leverage existing infrastructure and some of these new regulations on interoperability and information exchange, really continue this important momentum towards creating an interoperable and consumer-driven healthcare system. So with that, it's my privilege to introduce our guest speakers for today. First, we have Director Robert Gordon, who serves as the Director of Michigan's Health and Human Service Agency, which is one of the top agencies in Michigan and where he leads a staff of over 14,000 residents and oversees programs including Medicaid, Children's Protective Services, food assistance, public health, and many others. Appointed to this role by Governor Whitmer in January 2019, Director Gordon continues a career in public service that spans many areas of government, including the White House and U.S. Supreme Court. Director Gordon was among the leaders in the state to build the response to COVID-19 pandemic, and together with his colleagues has also worked to simplify and increase access to public assistance, champion reforms in the state foster care system, and expand the use of evaluation to improve programs of the $27 billion agency. We're also privileged to have Anish Chopra, who is the president of Care Journey, an open data membership service building a trusted and transparent rating system for physicians, networks, and facilities, and markets on the move to value. Mr. Chopra served as the first U.S. Chief Technology Officer under President Obama from 2009 to 2012, and has authored several important works, including Innovative State, How New Technologies Can Transform Government. He currently serves on the board of Healthcare Cost Institute and New Jersey Innovation Institute, and has earned his MPP from Harvard Kennedy School and a BA from Johns Hopkins University. Thank you, Anish. Bringing a clinical perspective, we have Dr. Tom Simmer. Dr. Simmer serves as the Senior Vice President and Chief Medical Officer at Blue Cross Blue Shield Michigan, where he oversees Michigan's medical policy and professional payment policies, and national programs to improve quality, cost, and access to medical services. Dr. Simmer is responsible for the reimbursement to more than 25,000 physicians throughout Michigan, and under his leadership has put important incentive programs in place to promote cost-effective ways to prescribe drugs and provide consistent care for people with chronic illness. Dr. Simmer also provides leadership to Michigan Quality Improvement Consortium, where he works with health plan medical directors across the state to create and put evidence-based guidelines into use. And last but not least, we have Dr. Tim Pletcher, who is the founding director of the Michigan Health Information Network and its subsidiaries. Dr. Pletcher is also the founding director for the Institute of Health and Business Insight at Central Michigan University, which provides high-end data science services to Fortune 500 companies and large organizations to extract insight and value from their data using business intelligence and predictive modeling. Dr. Pletcher has worked with the University of Michigan College of Engineering, as well as several other federal and worldwide organizations, including the Centers of Disease Control, United Nations, World Bank, and World Health Organization. And in his spare time, Dr. Pletcher serves as an adjunct research investigator of learning health sciences at the University of Michigan Medical School. So I want to thank all of our speakers today, and we look forward to this exciting discussion. Before we get started, I just want to point out that for the sake of time, we will be holding questions to the end. So please, if you have a question come up during the discussion, if you want to put it in the chat function, we will be manning the chat queue and collect those questions at the end and make sure we'll have plenty of time to go through some of the questions with each of our speakers. So with that, before we jump into the poly discussions, we really want to understand that so many organizations are in the thick of dealing with this public health crisis that we're currently in. I'd love to start the discussion by asking Director Gordon, if you could just spend a few minutes sharing from a leadership perspective, what are some of the greatest insights and potentially lessons learned you experienced during this COVID-19 crisis? And in what ways do you see health information influencing the current strategy and potential future strategy of our response?
Yeah, thanks for the question, and thank you for having me. It's great to be with all of you. At a super high level, we are enormously grateful for the many years of progress with MyHIN and health information, long predating my time here. And I think it is the progress and hard work on data infrastructure, data sharing, and common standards and common systems across programs is one of the reasons that we have been able to respond as effectively as we have. Obviously, COVID is a tragedy on a scale that none of us could have anticipated a year ago, and the lack of federal leadership has left all of us scrambling in a way that's unfortunate. But that said, we have worked enormously hard, and I think if you compare where we were in Michigan in the spring when we were absolutely clobbered by COVID early on, with where we are today, nothing can make up for the loss of life, but we are in a markedly better position than we might have been, and that is because of a partnership across thousands of people in this state, but a partnership that was girded by a strong data and information network. And some of the ways that I would highlight that that's true, very early on, we were able to establish dashboards and metrics for our progress, whether it was on the delivery of tests or contact tracing or the buildup of effective hospital beds and the number of beds we had. And to be able to know that information quickly in real time and act on it was essential. We've been able, using MyHand's data sharing in particular, to get testing reporting so that we are able to receive electronically data submissions from our labs and monitor and follow up. So we know quickly when there are problems, when things slow down, when we have problems in the collection of addresses. That's all information that we have in something like real time that I don't think all states have, and that we're fortunate to have because of MyHIN. We've, the challenge of health disparities, I think we saw early on, and the nation saw, to our horror, the degree to which COVID was clobbering African American communities in particular. So in Michigan in the spring, you had African Americans, about 15% of Michigan's population, about 40% of deaths in Michigan. It's come down a little bit since then, but obviously horrifying. Profound reasons of social injustice and discrimination are the drivers for that. But fundamentally, just to track it and know it, we have needed good data, and we were able to begin early on collecting race and ethnicity data around cases and around deaths. And I think that has enabled us to know a lot more than we might about what is going on with COVID and where it is going on. And then I think the last thing that I would highlight that's a related note is just when we think about racial disparities, some of it is about immediate bias and racial discrimination in the medical system, but a lot of it is about bias and discrimination and discriminatory access when it comes to the social determinants of health and things like housing and food and employment. This was a huge priority for us before COVID. I think it is more of a priority, or I want to say more, it is every bit the priority as we deal with COVID and come out of COVID. And I think, again, interoperable data collection is critical here because you really need to know, you want to have information about the person. A person isn't just a health life. They have life in employment and a life in education and a life, in many cases, in our human services system. And to be able to connect that information and use it, obviously, with appropriate privacy protections and consents, and use that information to provide people with the targeted supports that they need, just positions us to be infinitely more effective than if we're standing up programs without that information. So that's a little bit of a sense of how that I see sort of information infrastructure fitting into our COVID response.
Thank you, Director Gordon. I appreciate your time. Well, and it's clear that COVID has really reinforced the value of this health infrastructure and the need for public health response system. And I'd love to turn it to maybe Anish and Dr. Pletcher. How do you see public health intersecting with these interoperability rules and policies? In what way can this influence healthcare organizations' strategic planning?
Maybe, Tim, I'll jump in first, and I'd love having you follow up on some of the key points. Number one, obviously, it is critical that we build upon the foundation that Director Gordon just outlined. To me, this decade-long journey to invest in the digitization of the healthcare sector needs to be leveraged and reused as these emerging challenges come up. Public health reporting was not the driver of the initial $35 billion investment in electronic health records, but has obviously emerged as a very critical factor in filling in the data quality gaps. Race and ethnicity, as Dr. Gordon noted, nationally have been woefully underreported. And if it was not for the HIE infrastructure in Michigan, you probably would be just as challenged as the rest. So my initial assumption here is that organizations that are blessed with the infrastructure already in place should build upon that infrastructure and extend it. Obviously, for places that don't have the infrastructure, we're facing a conundrum of how to get what is essentially a decade-long experience underway much faster to meet the moment. My second comment, if I may, is that as we look to what the data gaps are, we see a very clear pattern emerge. We have very critical, timely lab results reporting gaps that should have the full contact information to enable a positive lab result to a contact tracing experience to sort of self-isolation and other patterns. Time is of the essence, and so that use case is probably higher on the order of priorities as we prepare for the next wave. But we also see case investigation gaps, knowing the patient's comorbidities and clinical history to better understand new challenges and changes to the threat vector will be similarly important, as well as understanding patients that are shown up in the ER, then get admitted, then have ICU admission, and so forth. So long story short, I think it's critical for us to take this moment and opportunity to build on the infrastructure and then to find these gaps that exist and to fill them with as much of this capability as possible.
Thank you, Anish. And I believe Dr. Pletcher had some issues with connectivity, and I believe you're back, Dr. Pletcher. If you want to weigh in on maybe some of those gaps and expand on that use of infrastructure for expanding on those. Maybe he's not back. Choice of virtual webinars, remote working.
A friendly opportunity to just maybe say a few more words about it, if I may. One of the interesting dilemmas here is that the industry is taking a look at all of the data elements that the government required. What's unique about public health reporting now is that the CARES Act effectively nationalized the data elements required for all lab results. And so I'm happy to get Director Gordon's comments about how he sees some of that, but HHS did declare a more robust set of information that's needed to be collected today. That includes asking at the time of an order for a COVID lab test whether or not the patients had been exposed, maybe they're in a nursing home or they're a healthcare worker, they're in a higher risk category. There is a set of these half a dozen or so questions that are to be collected now at every lab result. That's not really in the feed that comes in. And so we have to build out essentially, supplemental data infrastructure to meet that, as well as it's not historically been the case to send the entire clinical history of the patient alongside these sort of case reports. And both of these things represent new requirements on the system that today are largely met manually. And so one of the opportunities is for organizations that can send some of the data through an HIE, but are still manually grappling with the rest. It gives us a very clear near-term roadmap on what we can do to get those other pieces of information that are required, both to the state and local public health authorities, but in compliance with federal regulation.
I'll just add, and then I apologize, I'm going to have to jump, but Anisha's last comment made me think of a few things that maybe eventually talk with you. One of them is just that I do think it is true that this experience has lifted in everyone's awareness the importance of good health information technology and interoperability and data collection and data quality. And these are matters that might in our previous lives were for sort of wonks and tech geeks, and I include myself in the first category for sure, the last not the second. But now there are things that the governor asks us questions about and needs to know and pushes us very hard. Do we have the information that we need? Why can't we report in real time on school outbreaks? Why is contact tracing held back by problems with address matching? Why can't we do simple, we collect the names of long-term care facilities, but it's not so easy to break down what they are and what the outbreaks are. And why can't we do simple address matching that we all get every time we buy something on Amazon? And so I think that, and for us in Michigan, this comes back to, again, a disease surveillance system, which everyone in state government now has heard of and nobody had a year ago, that was built in 2004. And so these things really do hold us back in very vivid and striking ways. And so I think moving forward, we're acutely aware of the need to invest. There's money in the CARES Act that will help us to invest in these things, but obviously it's a much longer list of needs, and we should be thinking about not just what we need to do to deal with the next public health crisis, but the next crisis that isn't currently on our radar screen, but is coming. So I'll just share that thought, and just I think for someone like me who cared about this to some degree before, I care about it a lot more now because it's part of my everyday life. So thank you again for having me.
Thank you, Dr. Gordon. We appreciate your insight. Thank you. Well, with that, I think, again, a lot of organizations are really still focused on the long-term strategies, but the reality is that with the COVID crisis, many are still in budget shortfalls and trying to reevaluate resources and reprioritize spending. So maybe Anish and Dr. Simmer, from your perspective, are there funding strategies or opportunities that organizations should consider when planning for this work and addressing some of these gaps and needs that we've talked about so far?
Yes, thank you. The pandemic has created a broad awareness of the health and healthcare disparities in our society, and it's also created a consensus that we must act. And it's been well described already in this conference how the information sharing capabilities that were in place allowed us to do things that we could never have grappled with without that infrastructure in place. It also demonstrated the limitations or boundaries of that infrastructure. And everywhere the infrastructure was not yet in place, we found ourselves unable to deal with the situation effectively. That is primarily the information sharing infrastructure that we're talking about. As we work to address the health disparities and the healthcare disparities, we need interoperability because we need a much more robust data set. The reason is the method by which we will overcome these disparities is by changing healthcare so that the information is present at the time of care and the information is present to support conveners of improvement efforts. That interoperability is actually a broader, different, more challenging set of needs than the pure information sharing component. In organizations like mine, we already actively fund quality improvement programs to the tune of well over $50 million a year, and that's not including any of the incentive monies that can get up to over $200 million a year. And most of these efforts rely on manual chart abstraction. So overcoming that barrier will allow us to expand beyond these limited procedure-based quality improvement programs where we improve the care and outcomes of people who've had bariatric surgery, had knee or hip surgery, allow us to expand to the really big conditions that are affecting large numbers of the population, and particularly, and most importantly, there's high disparities with the minority community. So hypertension, diabetes mellitus, chronic kidney disease, asthma, chronic obstruction, the list goes on and on. This will allow us to fund programs that can be effective. And the one thing that's the common denominator of all these funding programs is, can we deliver value? It's easy to get funding for programs that deliver value by improving outcomes, and from both a human perspective and improving outcomes, because bad human outcomes are associated with bad cost outcomes as well. So getting funding for those type of programs is actually not difficult and hasn't been difficult. Overcoming the barriers and limitations of data collection through interoperability will allow that money to produce value, and then it will be able to significantly impact these health disparities. So I'm very optimistic about the funding, but only in the context of true interoperability that gives us the tools to create value, which is an absolute requirement for any significant funding.
Yeah, thank you, Dr. Simmer. And Anish, again, from a perspective, since again, investing in this infrastructure is so important, do you have any perspective on some of the strategies that organizations should consider?
Yeah, I couldn't have been more happy with Dr. Simmer's comments, because right now there are 3 effectively funded activities underway, but they're sort of their own entities. And if we found a way to pool them together and to build on progress, we may actually end up saving money, not needing more money, and accelerating. So let me just take a moment to explain that, because I do think it's critical. With Director Gordon's comments, we now know every single lab, which includes hospital-sponsored labs, must retrofit their IT systems to publish a data set that maybe they don't normally publish. And that is new work on top of what they've already done. And so people are doing that today largely manually. Obviously in Michigan with the HIE, yours is a less additional manual effort, but there's probably still some manual effort at every lab. So there's investments being made explicitly tied to CARES Act lab reporting requirements. Then, as Dr. Simmer noted, many organizations and I loved your language, Dr. Simmer, organizations that are convening the system to work towards value. That was a very elegant way of describing what is essentially ACO or bundles or value-based care arrangements. And many organizations across the state of Michigan, frankly around the country, they've been building, IT is often 30, 40, in some cases 50% of the operating budget for these entities who are helping organizations take risks. So they're already funded and they're putting their efforts, but to the point of chart abstraction, because the government didn't regulate clinical notes be made available through these sort of networks until maybe 2 years from today, there's a lot of manual work that has to be done to get the specific data elements that are needed for any of these individual models. But there is investment underway under this sort of value-based care programming. And given the timelines the federal government has set out, more and more of these organizations, providers, are taking on more and more risk with each passing year, compelling them to make more and more of an investment to study. When I'm taking downside risk, I'm nervous that I may end up having to write a check back for the services I offer. I need better information so I don't go blind into that decision. So there's already an investment underway. The third category is on the provider side and the payer side, which let's call this the compliance investment. And what that means is, based on the new rules, doctors and hospitals have to make investments to open up their information. Their EHR systems are going to have to upgrade and allow for, at a minimum, consumer apps to connect to their systems. But they have the technical ability to repurpose that same infrastructure to assist either in the public health use case or this care management use case. On the plan side, in particular, theirs is a shorter runway. Every health plan, government sponsored in the state and across the country, must have this infrastructure ready by July 1 of next year. That's a $1 billion capital investment nationwide, just sprinkled across all these different organizations. So, Melissa, to your question, if you summed up all the money for manual data collection for CARES Act reporting, for dealing with value-based care, quality measurement, care coordination, and compliance with regulations, and you summed all of that up, it is a multi-billion-dollar nationwide investment underway. However, if we could be more coordinated and thoughtful and take this urgency of now, of stitching these three actions together, and we had one robust infrastructure with policies that could turn on applications that meet certain legal and privacy requirements, riding on top of, say, the MyHIN network, we would be far better off, faster, and at a lower operating cost to the entities that otherwise are spending. So this could be a cost savings and optimization strategy as much as where's the new grant to get net new funding, which is also important, but that may be the 20% of the 80-20 rule.
Thank you, Anish. Yeah, it's clear there's a lot of priorities right now on people's plates to have to work through. Dr. Pletcher, I know you're back on. I'm not sure if you have any insight into some of those key infrastructure pieces that you believe the organizations should prioritize in their funding strategies or working through these next few years of their budgets. Oh, sorry, I don't think we can hear you. You might be on mute.
That my comment builds on Anish's, in that what we're seeing is each of those separate activities, value-based care, federal requirements, different initiatives, are actually acting a lot like stovepipes. They've got a team tasked with a high sense of urgency, and they are off chasing down their activity to try and meet their deadline. What I'm not seeing is this integrated approach where folks are making, check the box kinds of compliance, but really laying an infrastructure and a reusable capability so that they accomplish multiple goals later. And it's one of the concerns I have, is that folks are taking this precious resource and this urgent need to move forward where they're getting a lot of cooperation, but not really seizing the opportunity to get economies of scale and to sort of have reusability in the work that they're doing. So I think there's a real opportunity right now to align those kinds of infrastructure activities.
I see some thumbs up. Yeah, the industry talk has really been largely focused around these patient access and provider director APIs, but really there's a lot of requirements and movement towards improving care coordination and the flow, getting the data to flow better between payers and consumers. Dr. Pletcher, from a HIM perspective, can you please share some thoughts on how organizations can best leverage this rule set and some of the funding opportunities to really capitalize on this care coordination efforts and expand that value of ADTs that really are important for the consumers? I think your audio.
Yeah, thanks. Sorry for the pause.
Yep.
Yeah, so a couple of the things is there's this whole space of moving things over to FHIR and to sort of these public APIs. It is a force multiplier for multiple purposes. And the USCDI core is a sort of an organizing focus to sort of get things started. And, there again is sort of reusable ways to take what we've been doing and essentially align it with the activities that we're already trying to do, and just get at the data in a new way, but it gives us sort of much more expandability.
Yeah.
Well, sorry, go ahead.
If I could build on Tim's really important point, and I think this is the key. Prior generations of technology required any data that flowed through a pipe to meet the privacy and security arrangements negotiated through a governance process. And so we had a number of examples where, and this came up in COVID, by the way, where some of the national HIE networks had limitations that only allowed the data to be used for treatment purposes. And since public health reporting was not a treatment purpose, it had been a barrier in many of the states to allow that flow to be reused. It seems silly in the middle of a pandemic that the lawyers would have a debate about, is it treatment, is it authorized? it did require, for example, I volunteer in the city of Chicago. The Chicago Health Commissioner had to issue a formal declaration that electronic health record information is minimum data necessary for public health reporting. And only then did the lawyer sign off on information being able to be reused, even though the pipes were the same. So in the traditional sense of historical data flows, we had these agreements on what treatment is. But now with this scenario that Dr. Simmer outlined, where information flows not just to the patient and not just for treatment purposes, but potentially for these conveners to better organize the care delivery system, you start to get a little bit further away from those traditional governance models. This upgrade to the FHIR infrastructure allows us to have our cake and eat it too. And what I mean by that is one can have multiple applications riding this common infrastructure where this particular application, say for quality measure reporting, this is authorized for organizations that are in the quality program, but not for the rest. And you can be more refined in negotiating those sorts of provisions. As an example, this is what CMS does today. They have some funny engineers, so I'm going to use the acronym that they use. It's called the BFD. They built a beneficiary FHIR database. And they did this 2 years ago to meet the patient access obligations. Again, they didn't have rules at the time for themselves. They internally said, we want to give consumers access to their data. That was called Blue Button 2.0, if you remember the marketing campaign. But ultimately, that was built off of an infrastructure inside CMS called the Beneficiary FHIR database. As soon as that happened, the team that was responsible for value-based care, the Medicare ACO program or shared savings program, immediately said, we've got a subdivision of the country where we've got contracts. We want to give them that exact same data, but we don't want to give it to every institution, only those that have a contract. So they used the exact same BFD, just ran a new app. And so now any Medicare shared savings ACO in the country can connect to that app, and it's the same infrastructure that powers the consumer rule. Oh, and then they said Congress came up with a new law. Every Medicare Part D plan, the standalone Part D plans, they should be able to get access to beneficiary data for Part A and B. And maybe they detailed a bit more of a different data element. All they had to do is add a filter on top of the beneficiary FHIR database, and now they've got a third application. All three are in production today, and they're built on the exact same infrastructure. You lower the marginal cost when you have a common framework. And FHIR gives us a technical path to refine at the application layer those very complicated contractual negotiations. Is this going to be an always-on connection? Is it a one-time use? Is it only for value-based care and you can't reuse it for something else? You can be more precise in those at the applications layer if you had that common infrastructure.
In Michigan, we have the layer above that called the Active Care Relationship Service. So it actually creates a linkage from who's connected to whom, and it really lays a foundation that helps the trust framework come into existence, and it helps with a navigation layer. So you know where to go to get that FHIR information, but you also have a pre-disclosure that an entity or an individual has a relationship with that patient. So you still get that trust that you need, but then you get the reusability at the technical layer. And in terms of COVID, we've actually used that Active Care Relationship Service after we get all the data all the way to the state for the various kinds of reporting. We can take those tests and deliver them back to everybody else who's seen those same patients. And what it does is it allows you to close those feedback loops and enable trust and prospectively figure out who needs to know something. All of those things don't go away when you layer it on top of the sort of new capability. But that doesn't work if every group goes off and kind of builds their own little stovepipe. You lose the opportunity to reuse that investment.
I would like to add one point about the stovepipe, and that is, if we really want health equity, we have to realize that these stovepipes work to the advantage of those with resources, and basically those who are better off and aren't suffering the same level of challenges. One of the key components of a common infrastructure is that it supports all. An infrastructure stovepipe that serves a particular community or a particular payer or what have you isn't serving the needs of the community in terms of health equity and health care equity. The point is that just at my organization, we spend over $3 billion a year in diabetes care. We spend over $3 billion a year in chronic kidney disease care. It's amazing how much money we spend on these things, but we're not as proud as we would like to be of the care that $6 billion right there pays for. With these advancements in interoperability that are a common foundation across the entire society, we can deliver value in those very high numbers, and we are eager to commit the resources, eager to make the payments, because we have been in great need of better outcomes for our patients with those conditions. And of course, that is also equated with each of those bad personal human outcomes is associated with a significant amount of costs that you'd rather not be spending because you kept the person healthy.
Yeah, I don't mean to be piling on, but Dr. Simmer points out a really important subject. One of the most compelling investments that CMS has made in the last, call it 24 to 36 months on health equity was to universally reimburse for the diabetes prevention program. This has been a decade plus Centers for Disease Control best practice. And the actuary at CMS noted if everyone that was eligible for this model enrolled in it and got the weight loss that the programs have demonstrated, we would effectively save $4 for every dollar we spend as a Medicare on the Medicare budget side. So that was sort of Dr. Simmer's comment about the $3 billion. Here's the depressing fact, and this gets to the power of Tim's comment of acres. It was April of 2018 when CMS finalized the rule that every primary care doctor in the country could prescribe the diabetes prevention program to any senior who qualified. It was expected to hit hundreds of thousands of beneficiaries and make our health communities healthier. At the end of 2019, a whopping 800 people, not 800,000, 800 people used the service. If we had the ability to leverage some of these infrastructure investments with acres, and lists could be sent to every primary care doctor. Did you know you have this many patients attributed to you that are candidates for this free service? How many more patients would be enrolled in the program that's been funded? And our local Ys would have gotten some reimbursement to be able to build out their programming. We don't need a new act of Congress. We have a law, we have funding, it's on the books, and we just can't connect the dots because the people who are incentivized to connect it don't have the information they need. Busy doctors are busy. How do they know out of their 2,000 people in their acres list, these 65 would be great candidates? That would be the kind of service one could run if we had these sorts of pipes and programmings run through.
Thank you, Anish. And CMS is really noted, thinking about expanding about the use of FHIR and application in the industry and trying to bring it back to kind of interoperability rules that are in front of us. CMS has known this is the first step in a longer journey to building that interoperable health system that I think you all envision. I'd like to ask each of the speakers, maybe starting with Dr. Simmer, from your perspective, where do you see this journey going? And what are some ways CMS and maybe the industry can help the organizations get there?
The first thing is, and I think Director Gordon mentioned, we need more active disease surveillance, but we need to use this information to create registries and then support improvement efforts that surround registries that are populated using these advancements in information sharing and interoperability. This model of collaborative quality improvements, which we use extensively in the state of Michigan, has proven to produce very similar to the ratio that Anish mentioned of $4 of savings for every $1 in cost. Once we leverage this technology, I think we need to leverage that approach so that participants in those quality improvement programs can contribute to their success in value-based contracting efforts so that they're already aligned and in the game. But you do need to support them with this type of quality improvement infrastructure. We have 17 of these in Michigan today, and we're planning to significantly expand that number in anticipation of this advance in interoperability and information sharing. And so I think it's just, we have to use that approach. I think we're fortunate that this approach of registry-based quality improvement can become so much more powerful through these advancements. And I think that's what we're going to see as the main way where we translate information into outcomes.
Thanks, Dr. Simmer. And Dr. Pletcher, again, asking a similar question, where do you see this journey going? In what ways can the organizations be supported to get there?
So I think the world has, the 21st Century Cures Act said, oh, we need to have a provider directory. And I think we've said, hey, we need to do some stuff with FHIR from sort of the ground up. But I think the convergence of the public health crisis around COVID, the extreme realization that health equity is front and center, and we're not doing a very good job on that front, is going to focus a lot of our work on social determinants of health. And there's a lot of activities in our communities where we don't have decades of health informatics standardizing data. And so we're, with things like the Gravity Project, we're just getting started with really capturing that data in a consistent way. And so I think what we're going to see is folks rushing to say, okay, I need to share my data, I need to give it to consumers. And if they are at all clever here with the combination of rushing to do COVID and rushing to check the box by July of next year, what they're going to do is they're going to lay foundational components down. And they're going to say, but you know what? This is just a few first round requirements. There are many, many other use cases. So if you look to the Da Vinci stack of use cases, if you look to, not just Gravity, but also some of the Karen Alliance work, very quickly you see that we're moving into a space we've all said we want to go, which is consumer engagement. We want to empower consumers. And those of us in the interoperability space, we've been kind of talking about data liquidity for a decade, but it's actually starting to become a reality. And what we saw with the ADT use case, which again has been sort of at scale in Michigan since 2015, it takes time for people to understand how to harness the value. And so what I think is going to happen on this journey is that the clever organizations are going to get reuse. They're going to put in an infrastructure that allows them to build out multiple use cases, but then they're going to find ways to test and learn and test and learn so that they can run experiments about what do beneficiaries and patients need, and then they're going to learn from that, and then they're going to put in, okay, what capabilities get results? And that combination of a reusable infrastructure and a process to test and learn and figure out what works is actually going to line up really well with sort of future funding and the convergence of social determinants of health, health equity, and value-based care.
Yeah. Well, before we jump to questions, Anish, I'd love to get your federal perspective and your national lens to, again, understand where do you see these components merging in this longer-term journey to consumer-driven healthcare?
Yeah, I think the answer, building on where Tim just left off on reuse, which I think is the main theme for today's discussion, is to make a smarter first step. And what I mean by that is, if you're a physician, you have the choice how will you exercise the rights that the CMS rule has given you to communicate your list of patients to a doctor for purposes of getting an ADT message if they showed up in the ER? If that smarter first step is to leverage a reusable asset like Acres, or if it doesn't exist in your community, something like it, to communicate your roster, not only would you benefit from displaying that roster to every hospital, but oh, by the way, CMS has said, send me that roster and I'll give you a blue button data feed so that you get the claims history for those very same list of patients. So you can get the ADT feed and the claims history with one, upload to Acres or what have you. That would be an example of a smarter first step. If you're a plan and you're building a compliant service to give consumers access to the data that plan already holds, the smarter first step is to do what CMS alluded to in the final rule by saying, we anticipate, this is me interpreting the language, and you got to read the preamble in these rules, that plans will ask providers to negotiate application access as part of their contracts. So if you're going to do this to give access to the data for consumer-facing apps, a smarter first step would be to do a model provider contract that allows you to say, oh, by the way, I want the Acres equivalent app to be installed at your EHR so I can actually reuse for quality registries or any number of scenarios. And that's an option. It's not written in the rule that you must. It's sort of go for it. And if you're a health system and you're sort of grappling with all of this COVID reporting and you've got manual, data entry, and on the same time, you're trying to figure out how you're going to comply with this ADT rule, the smarter first step may be that instead of just routing one by one, Dr. A gets it this way, Dr. B gets it this way, by building on the same infrastructure, now the public health agencies who get effectively an ADT message, but for public health purposes, we can put the payload that they need through the same rails. And that has the, again, secondary benefits. So if you're looking at your teams that are saying, we got this covered, the rules are in, we're going to go, we're making progress, and you just sort of, okay, go for it, team. But you didn't do the due diligence on whether or not it was a smarter first step. Is it reusable? Give me the second use case that benefits from this infrastructure. Then we will find ourselves a year or two from now saying we have to double invest because Tom Simmer has come up with a new quality report that we want to participate in, and I got to do a whole new thing just to comply. That's not helpful for anyone. And I think that's what I would say, Melissa, is evaluate that smarter first step. If there's a +1 on the use case that ties to something that CMS is otherwise called for.
Thank you, Anish. And I know you've given organizations a lot to think about here, and we work through the next year or two, but I want to make sure we have time for some questions, but I know I found this discussion extremely valuable. So I want to open the floor to questions. I know we had a few come in through the comments, so please feel free if you do have questions from any of the discussions, please feel free to put those in the chat message, and we can try to get to all of them in the next 10 minutes we have here before we close. So again, thank you to our speakers for that, setting up that context. But looking to the questions here, it looks like the first one, what do Anish and Tim think health system IT organizations should do better to support this discussion?
Let Anish go first.
Yeah. So am I allowed to be a little spicy? I'll be a little bit spicy. Here's what I would say about it. Exercise your muscles. Exercise your muscles. So in the rules, now moving from CMS to the ONC rules, the information blocking rules, providers now have rights on their EHR vendors. And this is a critical right that starts in November, that enforcement discretion February of 21, but really the rules kick in November, and they are the following. If you're a provider, health system, doctor, and you're on a 2015 edition certified EHR, that means your software includes an API. If you're Epic, Cerner, eClinical, Meditech, Athena, you're lucky in that those vendors proactively adopted FHIR before they had to. So you have a FHIR API in your institution. But today, it's hardwired only to support consumer apps like Apple Health. Now that this information blocking rule kicks in, if you exercised your muscles, you can begin taking a portfolio of applications. Let's just say acres, because I think we learned today that's pretty important infrastructure. I want to connect acres to my EHR. Now you have a new option to connect acres to your EHR through a standardized, regulated endpoint. And you could exercise your muscles starting in November to say, I want that to happen. And if it doesn't happen, we can go back and forth. But that is a regulated opportunity where doctors and hospitals who are purchasers of these EHR systems can connect applications they trust. And it doesn't have to only be acres. It could be, the YMCA diabetes prevention calculator to see if you've got candidates that you'd like to nominate for this, or the Tom Simmers quality registry, which could be used. Whatever the answer is, exercise your muscles starting in November by making sure you can reuse the consumer-facing 2015 APIs for these broader requirements: public health, care coordination, and compliance.
Yeah, perfect, Anish. I agree, and I think I guess the offering in the my end market is we'll help you. We'll actually work with you to say, how do you get a little bit broader than your own EHR? And how do you think to be more inclusive? What we learned during COVID is while the EHR is important, it's not the sole center of the universe. And so your data needs to be integrated with other activities in the community. And so there's a really nice opportunity here to just, again, not get in pure vendor lock, control your own destiny, not share anything you don't want to share, of course, but subject to the information blocking requirement there. But really create a process that lets you pull together some things that historically have been very hard and have been an uphill battle. Now you've got the weight of the rule on your side, but now we have to figure out how to put the pieces together. And so whether that's getting set up in interoperability land or looking at an instance of the interop station, there's a vehicle now to begin to kind of cross a few organizational or vendor boundaries that historically would have been very hard, and now are going to be a lot easier if you're willing to put in the energy.
Thanks, Tim. Before we move to the next question, Dr. Simmer, did you have anything to add?
I only wanted to add that when we're talking about collaborative quality improvements, that's all patient on the list, not a particular insurer. And we can't introduce process variation through essentially many stovepipes interacting with each EHR and each provider. It really has to be promoting process integrity at the point of the provider so that all patients who meet those registry inclusion criteria are included. And that's how we're going to succeed in getting effective change within the practitioner community. This is not an insurer by insurer solution. That is the way, an insurer by insurer solution is the way you create health disparities, not the way you solve them.
Thank you. And speaking of whole patient, there was a question about how dental treatment fits into this equation. If any of the panelists have a insight into dental treatment.
I have one. I don't know if it's an insight, but I do have a twin brother who is a dentist, professor of dentistry at the University of Michigan, and he always asked me, where did I learn in medical school that the mouth is not part of the body? And the one thing I have is I was speaking with a CEO in Sweden of a health county plan, and one of their quality improvement measures was to increase the number of people living in their county that reached the age of 21 who never experienced having a tooth cavity. And when you think about it, that type of quality initiative is absolutely impossible here because of the way we have organized the information process around dentistry. We need to change the information processes around dentistry so we too can have those same public health goals. And it's a great illustration of how, if you want to really change the health of the community, it always relies on the information infrastructure as the foundation.
And just briefly on that, Melissa, since Medicaid processes a number of dental claims, by July 1 of next year for Medicaid managed care plans operating in Michigan and elsewhere, they're going to be exposing that sort of information, which is essentially one of the first times that data will be available for applications to use, whether they be consumer applications or in the case of this reuse, maybe the CQI framework, kind of multi-payer registry panel. So that is a in-scope data class on the Medicaid side.
Thank you. Yeah, and continuing on the whole patient, one of the questions came in related to the restrictions around mental health and how, in light of connecting patients with social determinants of health and community organizations, what are the panelists' I guess feedback in terms of whether or not you support a less restrictive health information exchange, mental health records, or should these be considered as part of this exchange? Are there still clinical value really in these restrictions?
I don't
I'll go first.
capitalize these. Yes, go ahead, Tim.
I was gonna, I'll go first and say, what we find is that opt-in and opt-out is entirely the wrong framework, and that it's not an all-in or all-out. It's an appropriate use and giving the consumer more both transparency and control of who you want your information shared with. Many of the activities around consumer access are empowering patients to get their own data. But most of the goal is for the patients to then be able to give it to the provider they want. And so I think there's lots of opportunity to increase really reduce the friction that it takes to get the information that you want shared. And I'll use an example of an advanced directive, where you work really hard, you hire a lawyer, you fill everything out to say, this is what I want my end-of-life condition to be. You get COVID, and then nobody actually looks at the data that you have on file. And so it's actually very important to be able to expose those preferences, those choices that people have. And so it's not just about saying, hey, I'm going to opt in or I'm going to opt out, but that here's who I want my data explicitly shared with, and here's where my personal preferences are. Now, in your workflow, go check in those places what my preferences are. And right now, we've kind of built a lot of framework on it. You can't see, you must not. And I think there's a lot of opportunity that says, please use my information in a certain way. Not disrespecting my confidentiality, but actually paying attention where you do want it used. And I think that part gets emphasized.
Yeah, and if I can make a friendly commercial, I'm involved in the Karen Alliance, and exactly what Tim is describing is sort of the next chapter of our privacy code of conduct to move from these, opt-in, opt-out models to essentially a control panel. And that framework of a privacy control panel, that is something that the broader internet community is beginning to move towards. You can say that I trust Dr. Rosenberg at the University of Michigan, and so I want him to have unfettered access to everything all the time. But this Tim Pletcher guy is a little sketchy, so I might give him a one-time token for the reason he's asked it for me. And so these sort of privacy control panels, this is not going to be a government-dictated model. I think it's going to be multi-stakeholder designed. So we're going to come together and say, what are the elements of it? How should we make it work? But please remember this. When the consumer accesses these two compliance APIs, they are doing so on the legal foundation of their right of access, which means the baseline is the consumer apps that are meeting the regulation get everything. You can't filter what they get. And then how they choose to share it that's where the need is for these control panels. It is really in the more traditional HIPAA treatment, payment, and operations where you've got these default decisions to remove it. So CMS blue button, when the consumer gets the blue button, it's the full information. When the ACOs or the standalone Part D plans do, it's filtered with the behavioral health, those sort of claims withheld. So Melissa, this new world of setting a kind of a control panel is in front of us. We can work together to design what that looks like and the experiences in a more agile, collaborative way. We're doing it now in the Karen Alliance Code of Conduct, and we'd like everyone to be a part of the discussion.
Thank you, Anish and Dr. Simmer and Dr. Pletcher. I know we can continue this conversation, I'm sure, for all day, but I know we're against time. Unfortunately, we're not able to get to every question, so please note that we will follow up with those that we weren't able to address after the call. But again, I want to thank everybody for joining us, especially our wonderful speakers today, and sharing some of their insights into how to best leverage these rules, and especially in this challenging environment. Just as a note, we will be posting this recording to the Myhan and Bellator website, so please check us out there. And if there's any comments or questions or feedback, we'd love to continue the conversation, and please reach out. We'll put my contact information up there. And again, we look forward to hearing with you. And again, thank you so much, everybody, and have a great rest of your start of your Monday and rest of your week.
So thank you very much.
Thank you.
Great job moderating, Melissa. Thank you.
Thanks, everybody. Take care.
Take care.